grad and postgrad here itself in Telangana, sir, from Medicity Medical Sciences Institute. Then after I did my MD in anesthesia from MNR Medical College, and I did a fellowship in pediatric anesthesia from IAPA body, sir, in Rainbow Children's Hospital.
Good. I think Dr. Suresh, you can
start, sir. Yeah. Good evening, friends and everybody. Welcome to the 25th episode of our Pudukkottai Budan and online weekly program by ISA Pudukkottai branch, a branch of Tamil Nadu State ISA branch. At the outset, I welcome our Secretary, Dr. M. Periyasamy, to welcome the gathering and introduce the speakers.
Thank you, sir. Thank you. Good evening to all. Respected Academic Chairman Dr. A.L. Meenachandram sir, President Dr. Suresh Kumar sir, President Dr. David, and members of ISA Pudukkottai. The branch hails from Tamil Nadu, India, and delegates, those who are attending this important milestone event of ISA Pudukkottai. That is, I want to mention this is the 25th online webinar ISA program. So I welcome you all for this historical event of ISA Pudukkottai. Once again, I welcome all the delegates, those who are attending this event from various parts of the country, and all members of ISA Pudukkottai, and delegates and speakers from various parts of this country, and others members of Anesthesia Society. And welcome for this Pudukkottai Budan ISA program. So already we crossed 24 events from 23rd March 22 to till date. That is 7/9/22. Last week we conducted a program on airway management, difficult airway algorithm, and nasopharyngeal airway. So this week is the 25th event of this ISA Pudukkottai event. There is Silver Jubilee event. This is a historical event. The man began this successful events is definitely our academic chairman, Dr. A.L. Meenachandran sir. At this juncture, I wish to welcome and thank him for his continuous effort and make this program one of the successful event in our ISA history of India. So once again, I thank you, sir, for this innovative event, and since because of you only we are focused to the country on irregular week of Wednesday. Once again, I thank you for this historical event, sir. And today, this week, we are going to invite our chairperson, Dr. P.V. Siva, for this event. He is a professor and of Osmania Medical College, Nilofar Hospital for Women and Children, Hyderabad. I welcome you for this event, sir, on behalf of ISA Pudukkottai. And another 3 speakers from various medical colleges. First, I welcome Dr. R. Chitra, resident, Osmania Medical College, Hyderabad. Madam is going to talk about Glasgow Goma scale. I welcome you, madam.
Thank you, sir.
Another speaker, Dr. P. Swaminathan, so well-known speaker and friend of our ISA Pudukkottai. Dr. P. Swaminathan, Professor Head of Emergency Medicine, Raja Muttaya Medical College and Hospital, Annamalai University, Chidambaram, Tamil Nadu. I welcome you, sir. Sir is going to talk about sedation in ICU setup. And third speaker, I invite Dr. Samir Iniyat, intensivist, Nilofar Hospital for Women and Children, Hyderabad. sir is going to talk about anesthesia management of congenital diaphragmatic hernia. This is very difficult to manage, the congenital diaphragmatic hernia. So I think this will be very useful for PGs and practicing anesthesiologists of the various part of the country. With this, I once again welcome and thank our academic chairman, president, treasurer, and ISA members of Pudukkottai for held this 25th Silosibly ISA program of this week. And one more thing, this already I mentioned that Medical Council of Tamil Nadu is giving credit hours. Those who are attending this event, those who want to this credit hours, they have to pay 100 rupees to the mentioned account number of this our ISA Pudukkottai bank account. You can note it down. More important is you have to pay 100 rupees left to the said account number. The whole information should send to ISA Pudukkottai at yahoo.com. This is more important. From this only we are picking up the members list. And today events, the brain. I choose this topic because the brain began this event is our academic chairman, Dr. A.L. Meenachandra sir. He only do all the things like our brain. So membranes hold the brain, making marvelous thought and ideas. CSF making them cool as pool to store unlimited old and new events. Recall them with no pain. It recreates events to gain. Brain, balancing the act and thought, reacting and reaching the fact, aiming high with a kind heart, inspiring everyone with evergreen memories, having noble vision and mission. So, brain is wider than sky and deeper than sea. Brain is nothing but God particles. With this, I thank one and all and thank our president for giving me this opportunity to welcome you all this 25th Silosibly CME online program. Thank you, sir.
Thank you, Dr. Periyasamy, for your welcome address and your poem on brain. Today we are going to witness the 25th webinar of our Pudukkottai Budan. Respected Secretary, Treasurer of our branch, Dr. Periyasamy and Dr. David. Respected Professor Dr. A.L. Meenachandra sir from of our academic wing of our ISA Pudukkottai. Today's chairperson, Professor Dr. P.V. Shiva from Nilofer Hospital, Osmania Medical College, Hyderabad. And Professor Dr. Swaminathan, a close friend of mine from Tanjavur Medical College, now is professor and head at Raja Mutaya Medical College, Chidambaram. Dr. Samir Inayat, an intensivist from Nilofer Hospital, Hyderabad. Resident Dr. R. Chitra from Nilofer Hospital, Hyderabad. With members who have come here, senior executives, office bearers of Tamil Nadu ISA and state and other national ISA branches, and dear postgraduates. On behalf of ISA Pudukkottai branch, I welcome you all for this gathering. At the outset, I thank our professor, Dr. A.L. sir, for giving us the opportunity to host the Pudukkottai Budan continuously for the past 25 episodes, and we are cruising very nicely for the focused 52 episodes. I thank on behalf of our branch our A.L. sir. I request all the members, postgraduates to utilize this program today and in coming weeks to update your knowledge, as we are focusing on so many useful topics which is vital for our practice and vital for our postgraduates for their examinations, clinical as well as practicals. So I request everybody to make use of this program. Now I hand over the proceedings to our academic chairman, Dr. Yailam. Over to Dr. Yailam. Thank you. Thank you.
Thank you, Mr. President, sir. It gives me immense pleasure to talk on the 25th webinar from Pudukkottai, titled Pudukkottai Budan. So, as our secretary pointed out, it is a silver jubilee, and we are really happy that we have introduced 100 faculty across the country so far. And the next week, we are going to have our 26th edition. We have targeted 52, that is for a year. So the 26 is going to be the coverage of 50%. And we have even requested our national president to offer a felicitation message and the state president to offer a felicitation message on that day. Hope we will cover this 52 weekly programs successfully involving faculty across the country. And this time we are happy to have the youngest faculty, Dr. Chitra. But now in the labeling, Dr. Chitra is labeled as Dr. Samir Inayat, and Dr. Samir Inayat is labeled as Chitra. That is the only thing they have to rename it. But Dr. Chitra, initially when the name was written as Chitra, I was wondering whether it is really Chitra or TH is missing. But her name is only Chitra only. So she's just like a female SPB, and a male SPB is Dr. Shiva. With the headphone and all, exactly he is mimicking SP Balasubramaniam of Telugu. So even that smile also mimics that. Dr. Chitra, surprisingly, she is from Pondicherry. So she knows Tamil very well naturally. And we are happy to have a Pondicherry doctor to have a post-graduation in Nilofer Medical College, that is Osmania Medical College. And we wish her all the best because she is having this platform with the top people like Dr. Inayat, Dr. Shiva, and Dr. Saminathan. So let it be a good beginning. And Pudukkottai Budan also has proud in introducing you across the country because the invite has reached 1,500 people, and we wish you all the very best, and we are here to listen to you on a Glasgow scale. So then another guest is Dr. Inayat. So surprisingly, Inayat, even though he is very young, he has covered MBBS, MD anesthesia, and also fellowship in pediatric anesthesiology. And my passion is intensive care unit. And Dr. Inayat is also taking part in that. All anesthesiologists should take part in intensive care management. And he has established himself as an intensivist. And he is managing the intensive care unit of Nilofer Hospital. And we wanted him to talk on pediatric anesthesia, which in the post-operative period requires ICU setup. So only in pediatrics, this TEF and CDH and CLE, congenital lobar emphysema, are the dire emergencies. And Dr. Inayat is very good in managing all these cases. And naturally, he is a good resource person for this Pudukkottai Budan on CDH. Then in the ICU sedation, Dr. Saminathan is here. He is a retired professor from Raja Mutaya Medical College, Annamalai University. And see, he has 3 parts in his life. So 10 years he has spent in general medicine. Then 12 years he has spent in anesthesiology. Another 12 years he has spent in emergency medicine, and he has created the emergency medicine unit in Raja Mutaya Medical College. And he was assistant professor, associate professor, professor in the same department. And whenever he is there in the college, he used to actively teach the life support program to the postgraduates and the CRRIs. So all the postgraduates and the CRRIs will be averse to him because whenever he is there, he will be teaching them. And that is the reason why after retirement, he has come to teach them through webinars. So he has his area of management interest is ICU. Actually, he used to train nurses also. So he is good at that teaching program. And the more surprising fact, in spite of being my classmate, he has become intelligent. That is the surprising fact. I don't know how it had happened. So suddenly something will happen like this. So I'm happy to have, he is the first classmate to address in this branch, Pudukkottai Budan. Now comes the vital part, the chairperson who is going to control everything. So we have a man looking like SP Balasubramaniam, but named as Shiva with a headphone and all. He is such a good personality, a humble person, honest person, ambitious. Whenever he is going to do some work, he like to do it with 100% perfection. So he used to have interest in serving the society, and he is always exploring the options to serve the society. So we, all of us, when he is deciding to serve the society, we have to help him. And he is the ISA Hyderabad city branch president. That is a vital part of it. He is a metro, Hyderabad is a metro branch. So he is a city branch president. And in the IAPA, he is a Telangana state president. And I have seen him in various conferences as a faculty, and he is a faculty in WFS also, World Federation of Anesthesiology, that is Safe Pediatric. And he is a member of inspection committee for various quality programs in various medical colleges. And he is also a member in selection committee for TSPSC, that is anesthesiology faculty. So he is a man who is in the topmost administrative post, but he is humble and down to earth. So we are happy to have him, and he was ready to suggest the name of Dr. Chitra and Dr. Inayat, the two youngest faculties, and naturally he is a good leader in projecting the juniors also. That's what is important nowadays. So now I hand over the session to Dr. Shiva. Sir, please take it over. Sir, you are muted. Dr. Shiva, sir, you unmute and talk. No, not audible. Dr. Shiva, sir, you are not audible. No, he is muted. Sir, you are muted.
Sir, you can unmute, sir.
Yeah.
Yeah.
But some audio problem is there. No, he got it unmuted, but audio is not getting connected.
Ask him to remove this headphone, sir.
Then you have to unplug. You have to unplug the headphone and use the audio of the computer.
Unmute, sir.
Okay, okay. Speak, sir.
No, he's
Not audible, sir.
Ms. Shilpa, can you check what is happening at his end?
Hello, sir.
No,
Hello.
Yeah. It's not heard.
Hello.
Before 6 o'clock it was heard.
Hello, Suresh sir.
Yeah,
Adani?
I think it tells to continue, sir. Shall we ask our resident to open the?
Yeah, one second, but we will call him over phone and we will tell him.
Yeah.
Yeah, he's joining through phone, and I request Dr. Chitra to go ahead with her talk on Glasgow coma scale.
Okay, sir.
Yes, she's in. Unmute, sir.
Good evening, everyone. First of all, I would like to thank Dr. ALM sir for giving me this wonderful opportunity to talk in Pudukkottai, Bhutan. And also, I would like to thank Suresh Kumar sir, Swami sir, and also Swaminathan sir and the entire ISA Pudukkottai team. And I would like to extend my thank you to my professor, Dr. Shiva sir, for choosing me and guiding me in this topic. My topic today will be Glasgow coma scale. The objective of today's topic are introduction, components of GCS, scoring in adults and pediatric age group, and how to perform GCS, the classification of severity, application of GCS, limitations of it, and what are the other scales. GCS was first published in 1974 in the University of Glasgow by the neurosurgery professors Graham Teasdale and Brian Jennett. That is how the name came, Glasgow coma scale. This is the most commonly used clinical scale to assess the extent of impaired consciousness in all types of acute medical illness and trauma patients. As we all know, the three components are eye-opening response, verbal response, and motor response. And these GCS scores are expressed as EVM. It is not expressed as the total score. It should be mentioned as EVM. And the maximum score is 15 and the minimum can be 3. The scoring system in adult patients are for eye-opening. The maximum score is 4, which is spontaneous eye-opening, 3 to each. 2 is for painful stimuli, 1 when there is no response. And verbal response, 5 is for when the patient is oriented, 4 is when the patient can make meaningful sentences, 3 only words, and 2 only sounds, and 1 when there is no response. Motor response, highest score is 6 when the patient obeys our commands, and 5 is when the patient localizes the pain, 4 is when he withdraws to pain, 3 is abnormal flexion or decorticate posturing, 2 is abnormal extension or decerebrate posturing, 1 is no response. And this chart explains the difference between adult and infant GCS. For eye opening, it is almost same. It's like spontaneous and verbal stimuli and painful stimuli and no response. As verbal component is not much developed in infant and pediatric group, it is little bit different than adult. Where for score 5, when patient is oriented to time, place, and person in older children and adults. But in infants, we can see when the baby who's are babbles, we can score it as 5. And 4 is for confused conversations. In that, for infants, can have irritable crying. And 3 is in the inappropriate words in older children, and infants will have crying on pain. And incomprehensible words for a child, older child, and for infants, baby will moan for pain. And 1 is there is no response. For motor response, it is also more or less similar. For 6, patient obeys the verbal commands in adult and older children. For infants, they do a normal movement of limbs. For 5, the older children will localize the stimulus. In infants, the baby will withdraws upon touch. 4 is withdraws upon pain. 3 is decorticate flexion. 2 is decerebrate extension, and 1 is no response. How to perform GCS? It is very important because the appropriate method of examining the patient should be learned, and the same way it should be assessed, because two different person can assess the patient and can give two different GCS scores. For eye opening, we should go to the bedside of the patient and observe the patient. If the patient is opening his eyes spontaneously, that is unprompted eye opening should be there, then we can score him as 4. If there is no eye opening, we can ask the patient, we can call the patient by his name, or we can tell the patient to open their eye. That is to speech, that scores us 3. And if patient is not opening the eyes to speech also, we can give a painful stimuli. The painful stimuli are trapezius squeeze, supraorbital pressure, nail bed pressure, sternal rubbing, like that. Even for painful stimuli, patient is not opening eyes, then the patient is not responsive, so we can score as 1. If there is a primary ocular causes like swelling, edema, or dressing, then the patient is not able to open their eyes, so we can mention it as not testable or E1C. The C is for closed. These are the painful stimuli like trapezius squeeze or supraorbital pressure. Next comes the verbal component. Verbal component, when we ask a patient for orientation to time, place, person, when the patient is oriented, we can give 5. If the patient is not oriented, but still he can manage to make a meaningful sentences, then it is 4. But patient cannot make a sentence, but he can just saying words which is not relevant to context, then it is 3. And patient is only making some groaning noises, it is 2. And there is no response at all, it is 1. Whenever the patient is intubated in ICU setups, like when patient is intubated, we give them as a score as VT or V1T. The presence of speech indicates high degree of integration in the nervous system. Next comes the motor response. Actually, motor component has proven to be the best predictor of survival. The maximum score is 6. When we ask a patient to do some like raise your hand or grip my finger or make a fist, when the patient obeys the command, then we can score them as 6. When the patient is not able to obey our command, but when you are inflicting a pain and patient can localize the pain, then it is 5. But patient is making a flexion or withdrawal away from the painful stimuli, it is 4. When there is abnormal flexion like adduction and internal rotation of arms, and it is known as decorticate posturing. It suggests the damage above the level of the red nucleus, such as cortical or thalamic injury. Now, score 2 is the decerebrate posturing, which is the extension to pain in an abnormal response consisting of elbow and wrist extension, usually with leg extension. In this case, the damage is below the level of red nucleus, in such as brainstem injury, and indicates severe brain damage. 1 is when there is no response. So these are the pictures showing localizing the pain. Here the patient is localizing the pain in first picture. The second is he is moving his limb away or he is doing a flexion. That is score 4. An abnormal flexion, this is adducted and internally rotated. That is decorticate posturing. And this is decerebrate posturing. This is adduction and extension of the hand. This is classified based on the score as mild, which is 13 to 15, moderate is 9 to 12, severe is 3 to 8. The GCS score, when it is 8 or less than 8, it is the point of intubation, because the patient cannot maintain a patent airway. Application of GCS, it is a very simple tool used by the physician, nurses, and even paramedics. It describes and assesses the coma, monitor the changes in depth of coma, indicator of the severity of illness, and it facilitates the information transfer, used as a triage tool in patients with head trauma, and also rapidly detects a complication even in patients with GCS of 13 to 15. And there are some limitations to GCS. like the skill of the observer. Two people might score a GCS assessment differently, especially if not trained. And in most of the ICU patients, they will be sedated and intubated. And in case of spinal cord injury also, the motor component is invalid. In case of intoxications like high blood alcohol concentration or severe facial or eye edema and injury. When a component is not testable, we can mention it as NT. Or if eyes are closed or swelling edema is there, we can mention it as E1C or EC. And in same way, intubated patients who is on ventilator also, we can say VT. And in case of head trauma, the GCS has to be assessed after 6 hours of the head trauma. And these are the conditions which affect the calculation of GCS, like ocular trauma, cranial nerve injuries, pain, intoxication, medications like sedatives, and dementia, psychiatric diseases, if any previously, developmental impairments, no comprehension of the spoken language also, intubation tracheostomy, edema of the tongue, facial trauma, mutism, hearing impairments, and injuries like spinal cord or peripheral nerves. There are other scales like Glasgow Coma Scale Pupil Score, which is described by Paul Brennan, Gordon Murray, and Graham Teasdale. It is the we have to score pupil reactivity score. When the pupils are unreactive to light, when both pupils are unreactive, it is 2. One pupil is unreactive, then it is 1. Neither pupils are unreactive, and it is 0. So we have to minus the pupil reactivity score from GCS. For example, if a patient GCS is 8 and both the pupils are unreactive to light, we have to, that is 2. We have to subtract 2 from 8, then the GCS becomes 6. And these are the other scales like full outline of unresponsiveness, and AVPU scale, and ACDU, and World Federation of Neurological Surgeons scale. To summarize, GCS carries the valuable information regarding the neurological status of the patient, the course of prognosis, or any complications of the patient. So adequate knowledge and about the scoring system based on proper examination and its importance limitation is important for its appropriate use. These are the references. And thank you everyone for giving me this opportunity.
Thank you, Chitra. Am I audible?
Yes, sir, you are audible.
Yes, sir. Yes, sir.
Yeah, that is a nice presentation. What is your limitations with GCS?
So limitations are when patient is.
Sir, Shiva sir, questions at the end, sir.
Okay, sir. Okay.
Yes, Mr. I will share my
Section.
Dr. Shiva sir, you are not audible.
Yeah, no. Am I audible?
Yes.
Yes, now is audible.
Yeah. Now, shall we proceed with the second speaker, sir?
Yes. Shilpa, you can screen it.
I request Dr. Swaminathan sir to give a lecture on ICU sedation.
Thank you, sir. Thank you, sir. So Shilpa, can you share the screen? Good afternoon to everyone. This is Dr. Swaminathan, Professor Dr. Swaminathan, HOD, Emergency Medicine, just retired in Rajamute Bari College Hospital 2 months before. I feel pressure to be with you for giving a talk on sedation ICU on this Pudukkottai Budan weekly online seminar. My first thank to Dr. Meenakshi Sundaram, who was instrumental in bringing out this Pudukkottai Budan for every week for academic fees to the residents and the postgraduates and junior doctors of this specialty. My special thanks to Dr. Suresh Kumar, President, and Dr. Perisam is our Secretary, ISA City Branch, Pudukkottai. Now I'll move on to this specific topic, sedation ICU. Introduction. Critically ill patients are routinely provided analgesia and sedation to prevent pain and anxiety, for permitting invasive procedures, for reducing the stress, oxygen consumption, and improve the synchrony with ventilator settings. And how to go into the module giving the sedation is these are combination protocols like giving analgesia, sedation, and with targeted arousal goals and daily sedation interruptions. And patient is being allowed to awakening with breathing trials and early mobilization from the bed for better results in ICU settings. The points to note in ICU patients will have altered pharmacokinetic effects, multiple drug therapy involved in ICU patients, and individual responses vary from drugs to drugs. There is an interaction of drugs happens among the drugs given to the patients. There may be decent need for intervention procedures to be performed during the ICU state. What are the indications for sedation agents is to keep the critical inpatient with the comfortable settings, and for doing some procedures like intubation, and we will reduce arousal, reduce anxiety, and keeping the patient repeated arousals, and promote amnesia. For something events happen in the ICU. Patient need adequate rest, and to avoid unpleasant situations, and to reduce awareness of the environment. All those goals needed for indication to give a sedative agents. How the ideal sedative should be like quality of sedative should be having qualities of hypnosis, induce sleep, reduce anxiety, produce amnesia, onset is rapid, do not do any cumulative effects. It will be devoid of any renal or hepatic dysfunctions, not to produce any respiratory cardiovascular depression with the moderate doses. Some should have anti-cancer properties also. No long-term psychological effect should be there in the medicines. Last, not the least, it should be cost should be moderate. How the levels of sedation has been defined is minimal sedation, moderate sedation, and deep sedation. Minimal sedation is drug-induced sedation. Patient will be arousable and verbal commands itself. All reflex will be impaired. Ventilator cardiac function is maintained well. Moderate sedation, that is other name called conscious sedation. Patient will be arousable on tactile stimulus, other functions and vital form monitor, airway, everything will be maintained. Patient maintains spontaneous circulation, spontaneous ventilation, cardiac function will be maintained. Deep sedation, deep sedation needs deep painful stimuli only. Patient is arousable. Patient will be deeply depression of conscious will be there, and the reflex will be also blend. Sometimes they need airway support, and ventilation may be assisted ventilation may be required in a deep sedation. So status cardiac function may be maintained well. What are sedation common agents is come across in our practices? Benzodiazepine, as you all well known, amnesia, hypnosis, anxiolysis, muscle relaxation, and anti-convulsive properties have, but the only negative point is it does not have the analgesic property. You need to have higher analgesics. First and foremost, drugs will discuss midazolam. It has got a rapid onset. Normal ACE start to 0.5 mg per kg in children. Children need higher doses. Onset is very short, 1 to 2 minutes. It will last for 20 to 30 minutes. 1 mg per hour or 2 mg per hour infusion depends upon the sedation score, age factor, weaning plan. Other systemic diseases also to the patient is restriction of sedation. Common adverse effects you come across: paradoxical reactions, excitation happens in children. Extremely safe when you use midazolam with the fentanyl. Dose-dependent hypoxia, patients go for a hypoventilation sometimes. Prolonged effect may happen in elderly as patients go for a redistribution and obese patient with liver function, impaired liver function. Barbiturates is next, not is commonly used for induction agents in anesthesia, and it is again negative point is it is anti-analgesics. Positive point is hypnosis, amnesia as an anticonvulsants. Short-acting benzobarbiturates, dose is 5 mg per kg. Effect is one arm circulation time, we used to say 60 seconds. Sometimes it takes 2 minutes. Duration is only 30 minutes. Adverse effects is respiratory depression, hypertension. Sometimes is accumulative effect, prolonged recovery in some other patients in elderly. Next is a ketamine, pencycliderivative drug. It is a dissociative agent. It dissociates the thalamocortical and limbic system from the cortex. Cortex and cortical system and limbic system will be disrupted. And higher center perceiving visual, auditory, painful stimulus will be blunted. It produces profound analgesia, amnesia, and catalepsis. Does not produce unconscious, but rather trance-like state will be. Nystagmus, rowing eye movements, random body movements will be there, but positive is air reflex will be protected. Coughing, swallowing, muscle tone tongue firings will be preserved. In a well-tolerated reactive airway disease like bronchial asthma, dose is 1 to 2 mg per kg, duration 15 minutes. Children is 4 to 5 mg per kg. IM, per oral, per rectal also can be used. Common adverse effect is unpleasant vivid dreams and hallucinations. Emergency reaction is worsening in this compound, but patient is going for a transient apnea. Catecholaminergic tendency to hypertension is common with this, so it is avoided in cardiac patients and hypertensive patients. Increase ICP and IOP. It is better to avoid in head trauma and open globe injuries. Laryngospasm in small infants less than with acute URTI. Laryngospasm also happens when the patient is in an inadequate analgesia. There will be increased brachial secretions. Adding glycopyrrolate 0.01 mg per kg 10 minutes before ketamine usage is beneficial for the patient. It produces increased elevation in normal situations. There is sometimes interface in problem when you are using a BiPAP mask. It's a mask interface will be difficult if there is an increased elevation. Full dissociation is possible with ketamine, may be useful in intubated patient with status asthmaticus. So agitation recovery, refractive to other agents, maybe ketamine will be better choice. Agitation, profound hypertension will be useful in use of ketamine. Complete dissociation 1.5 mg per kg per hour. Partial dissociation 0.1 to 0.2 mg. The titration may be increased, depends upon the response. Co-administration of propofol may avoid ketamine-induced dysphoria-like pictures. Propofol. Next is a commonly used drug, short-acting symptomatic, the phenol derivative, direct membrane effect as well as GABA receptor action, rapid after 6 to 8 minutes, high lipid solubility, easily penetrating lipophilic CNS, 0.5 mg per kg bolus, induce apnea and rapid high doses, 0.25 to 0.5 mg per kg allocates till the desired level of sedation is achieved. Onset at 1 minute, last for 10 minutes. For long procedures, 2 to 3 mg per kg per hour may be titrated, depends upon the duration of procedures. In ICU patients, 0.25 to 0.5 mg per kg per hour, repeat wherever is required. Hemodynamic stability to be watched, especially in patients consuming OPC poisoning and to mixed poisoning cases. There will be transient hypertension happens. Don't worry about, do not panic. Watch for hypertension for next 2 hours and stop the infusion temporarily and give a bolus of fluid. That will be hypertension will be nullified. Then comes propofol infusion syndrome. Rarely it happens. The patient receives more than 4 mg per kg per hour continuously for 48 hours. It may produce a rare occurrence. It's a potent muscle relaxant also. It has got other anti-emetic properties. It reduces a rise in intracranial pressure. Lipid formulation component of propofol is good for bacterial growth. So syringe should be capped. You should not keep the syringe open. Open then while open syringe vial to be discarded within 6 hours, not to keep the open vial for more than 6 hours. The high sulfate concentration can induce bronchospasm and asthmatic patients. Other side effect is hypertriglyceridemia. Triglyceride levels may be monitored every 48 hours. If a level goes more than 800 milligram per deciliter, needs to be stopped. Green urine may come in some of the patients who receive propofol. Does not correlate with propofol infusion syndrome. Hypotension is a relative contraindication, can be managed with the low dose of vasopressor infusion if needed to counterbalance the vasodilation to propofol if the propofol is only choice of drug to be used. Then comes not least is tranquilizers. It forms a part of ICU management in some patients which need anti-psychotic effects, and it is butyrophenones and phenothiazines. It acting via dopamine D1, D2 receptors, and it does suppress histamine and serotonin cholinergic receptors. Main action is reduce motor activity, apathy, reduce initiative, sedation, drowsiness, aggressions are reduced. Another property is antiemetic. Haloperidol, how it is given? It is given in a diluted 1 milligram per ml, given as liquids up to 5 to 20 milligram per hour until delirium patients become calm and quiet. It has got IM oral application also available, not to be used for long-term sedation. Large dose can be used in difficult situations. The patients become restless, irritable, and acute psychosis. Delirium patient may be risk to the other patients inside the ICU. Another drug is olanzapine. It's an antipsychotic drug. It's available as a oral form only, 5 to 20 milligram per day. Lower side effects with respect to motor activity. Adverse effects is extrapyramidal. Anticholinergic effect is dry mouth, constipation, hypertension, rarely endocrine effects. Sedation comprises analgesia also. Pain management is also one of the main part in ICU to be managed. We allow the pain to persist. It not allows the patient to go for sleep. It worsens the delirium. It increases the stress response and results in respiratory embarrassment. It makes lung expansion reduced and make the sputum get retention. And other effects is venous stasis and gut stasis. Other effects of long-term ventilation. Pain management alone added to it when the patient is under general anesthesia, other care like nursing care all to be taken into account when the patient is in ICU for a long period of time. What are the drugs, analgesics to be used in the practice? Opiates, tramadol, and NSAIDs is commonly used. Another modality of suppressing the pain is acupuncture, acupressure, massage, and TENS. Bad effects of opiates is that is got it other effects of opiates. And the action morphine is a common drug come across in regular practice. 1 milligram per ml as infusion, titrate to the patient comfort. It can be combined with the benzodiazepine to produce sedation. Analgesia and sedation is a combination. It may be administered to other route of administration is subarachnoid, extradural, or intranasal route. Next, potent fentanyl, which is now common practice, is synthetic opioid, rapid onset, short duration, no histamine release. It is good for cardiac patients. Rapidly cross the blood-brain barrier, produce analgesia in 90 seconds. Duration is 30 to 40 minutes. Half-life is 90 minutes, 1 to 2 microgram per kg per minute. Lower doses for elderly and alcoholics. In general, other route of administration, transmucosal route, and lollipop-like fashion. It is not practiced, but it's available in some centers. Remifentanil is a newer drug. It's a potent mu opioid receptor agonist, metabolized by non-specific blood and tissue stresses, rapid metabolism, and used for anxiety sedation in ICU patients. It's good for weaning trial patients and extubation times. It's better to use instead of fentanyl. You can use remifentanil as a choice when you're planning to go for weaning trials. Next drug is dexmedetomidine. It's alpha-2 agonist. It has got a property of both analgesia and sedation. Loading dose 1 microgram per kg, 10 minutes. Infusion is 0.2 to 0.7 microgram per kg per hour. Infusion is to be restricted to less than 24 hours, not to cross more than 24 hours. Hypotension, bradycardia, rarely atrial fibrillation. Infusion is 0 to 1.4 milligram per kg per hour. Stopping dexone during the day may help to avoid tolerance. Withdrawal response may be there. Use of dexamine during night may promote good sleep and reset circadian rhythm. Good sedation, moderate sedation maintained during extubation period. It may be used for non-intubated patients like BPAP also, BiPAP, bi-level positive airway pressure ventilation. Bolus doses are not recommended as they produce bradycardia and severe hypotension. There are different terminology I'm going to use is multimodal sedation and titrable sedation. All this matter. Regularly, just saying it as how to add drugs and put a name of multimodal sedation. So multimodal sedation, nothing but multiple drugs can be combined to reduce the individual drugs of maximum dose. Moderate and minimal dose can be combined. We have a better sedation and better outcome from sedation. Titrable sedation is possible in drugs like propofol, ketamine are used for titrable sedation. Sedation means we cannot go on giving the sedation throughout the day. There should be some basic concept. When you stop the sedation, when you titrate and give, depends upon the individual patient's response. Again, when you use different combination of drugs, there should be some sedation interruption happens during the day, and sometimes top up may be needed in the nights. Do not shut off the sedation at the moment. It may produce unrest behavior among the patients. So taper off sedation and stop. Do not shut off sedation in a robotic fashion. These opiates, when you use opiates, severe hypotension, there's got a prolonged effect, accumulation effect will be there. That arousal may be delayed when you use opiates in a long duration or continuous usage, long acting. Not that the least, but we will go for a sedation scales, different sedation scales, what do you come across? One is a Ramsay sedation scale. He'll assess how much is the depth of patient sedation. Another scale is Richmond agitation sedation scale, which assesses the level of arousal from sedation. So, first we will discuss about Ramsay. There are 6 sedation scale: anxious, agitated, cooperative, response to commands, exhibit brisk response and stimulus. Patients exhibit sluggish response rate stimulus. There is no response, put it to the patient on the sedation scale 6. Arousal response, how to assess arousal? When you given a full sedation, you are observing the patient, you should arouse the patient. How to arouse? When you plan for arousal, patient will be compared to when you give deep sedation, agitated state, and very arousal. When you arouse the patient become very agitated. It is a +3. It is agitated +2. Just restless only when you tap the patient is +1. If the patient is quiet and calm, you can plan of arousal maybe continue. The patient appears alert, calm, and drowsy. Light sedation, moderate sedation, deep sedation, unarousable state is a deeper sedation. And go from below up, and level of sedation is above down, and arousal is below up, or unarousable to alert and calm. You keep the patient in +1, alert calm to -1 to alert calm. That's the safest way. 1 or 0 and -1. You cannot keep it for restless state or a unarousable state when you're planning for a RAS 1 scale is a patient sleeps comfortably. RAS 0 is during the day, maintains RAS 0. When the patient consumed some poisoning, the toxic dose of compounds and needs naloxone like antidote as naloxone. Naloxone is a competitive antagonism for any type of opiate or overdose or unwanted leap. Some psychological, some suicide attempt the patients is consumed opiate compounds too much. You need to go for an antagonist to be used. Time is administered to the IV route only. Sometimes you have to use a ET route also you have to use. 0.2 to 0.2 milligram every 2 minutes. Complete reversal. Desirable happens. May precipitate withdrawal symptoms. Sometimes when the patient comes out, patient produces withdrawal symptoms also. Rarest risk is patient may produce a pulmonary edema or seizures. Flumazenil is an antagonist for diazepam. Benzodiazepine compounds, 1 to 2 minutes, peak effective 5 to 10 minutes, effective in reversing the paradoxical excitement in children. The side effect happens within 1 to 2 minutes, maximum dose 0.02 milligram per kg, maximum is 0.2 milligram. So, withdrawal symptoms from opiates, irritability, tremors, aggression, fever, diaphoresis, piloerection. Symptoms may be controlled by combination of drugs like long-acting opiates, benzodiazepine, alpha-promised. Other effects is pethidine interaction with the MAO, inhibitors, precipitates, seizures. Pharmacokinetic sedation analysis can be affected with the following points. So, patient fluid status to be assessed. If there is any capillary leak-like situation like sepsis, there may be changing volume of distribution will be changed. You would assess and give the drug accordingly. Low hypoproteinemia state, you would restrict the usage of opiates and analgesics. And renal hepatic dysfunction patients, hepatic reduced blood flow patients, and cirrhotic patients, you have to reduce the usage of drugs, analgesic, any sedative to be restricted, and half, sometimes 1/4 of drugs may be used even in adult patients. What common analgesic you come across in ICU patients? NSAIDs and paracetamol. Tramadol is a regular use drug. It acts via mu receptor. It inhibits the uptake of serotonin release, enhancing the effects of descending analgesic system. Dose is 50 to 100 milligram. What other modes you can do? Time order. What other modes you can, other drugs can be used is local anesthetic agents, lignocaine, bupropion, inhibits anal conduction blocker, Jordan channels. It can be infiltrated as field block around the wound areas. Use a lesser kind 0.5 to 1% lignocaine and 0.25 to 0.37% bupropion can be used for peripheral nerve block. Pain on injection can be reduced by adding bicarbonate solution, 1:10 dilution, when you're giving a lignocaine with epinephrine, without epinephrine, with epinephrine 7 milligram per kg, without epinephrine 4 to 5 milligram per kg. These are available. Hemlock cream is, I think, is available now. Percutaneous painful procedure for children. Can apply a thin stratum of permits a good penetration of topical anesthetic to underlying nerve endings. So starting an IV line, you just scrap it over the area of going to start IV line, and after 30 minutes you can puncture the line. The children may be cooperative without giving much disturbance. Other regional blocks can be used for any surgical problem patients. We need to go for ICD or any procedure in the ribs or application of some elements, intercostal nerve blocks, fracture femur patients, femoral nerve blocks, thoracic epidural for any thoracic procedures, or ICD, or any procedure like a pericardial tapping, other things can go for thoracic epidural, and femoral nerve blocks for lower limb procedures, lower limb any international procedures, and intercostal nerve blocks for chest related procedures that will be useful for reducing the pain. The patient is in ICU. This is not commonly practiced alternative anesthetics in regular practice. If you have got a good anesthesia machine like workstation like within the ICU, you can go for use of local anesthetic agents. That the cost and availability of vaporizers is the main point, but can be used if it is facilities are available. Etonax is a procedure now practiced by the obstetricians, but is regularly used by the general surgeons. It is given text, but its usage is very limited. Then comes not a least one, but muscle laxant usage normally for all ventilator patients in ICU need to be given muscle laxants. with induction of GE or with deep sedation, and the patient is to cooperate with ventilate settings, we need to give a muscle relaxants all the time. These are all the other effects of muscle relaxants. Facilitate venous drainage, impacting hypertension, and reduces oxygen consumption. Specific treatment for muscle spasm in tetanus patients can be given as IV route. It can be given as an infusion. Intermittent bolus doses can be given to facilitate the mechanical ventilation of proper. Eccrine is commonly used to drug. First choice freely available 0.07 to 0.1 milligram per kg as a dose, 1 to 2 milligram as an infusion for first 48 hours. Top up dose depends upon the requirement. Muscle relaxant dose restricted when they're planning to go for any prayer and to maintain during the time with the minimal and moderate sedation. Restrict use of muscle relaxant to make the patient comes where regain power of muscle power. Then another drug is heterochrome can be used in the patient's liver and hepatic renal impairment patients. This can be used 0.5 milligram per kg as a loading dose. Can repeat it 0.1 to 0.2 milligram per kg as a repeated dose. It is eliminated bypassing the liver and kidney. It's called as Hoffman elimination. Choice of muscle relaxant is what I said is non-depolarizing muscle relaxant choice. Then comes as a depolarizing muscle relaxant choice, that is acetylcholine. It's a short-acting drug. It can be used with caution in multiple injuries. Single dose use can be used. Can be used in multiple injuries, renal failure patients safely, and burns patients. Restricted use of the low dose once a while can be used. It can interfere with the metabolism of potassium, so restrict the use of burns. Non-depolarizing muscle relaxant is what I said this earlier. What already described earlier slide itself. How to assess the recovery of muscle relaxant is train up for post-tetanic sounds and double burst stimulation. And can be relaxed, relaxing can be rest. Sometimes you would restrict relax an alternate day or half a day we'll skip off and restart and maintain intermittent with minimal sedation. Drug-free period can be combined. Muscle relaxant drug-free period may be combined with the sedation-free period intermittently. So drug, sedation drug and relaxant drug may be intermittently given mixed. It depends upon the patient's requirement. And assessing the neurological assessment may be easier when you restrict the sedation. The patient is neurological arousal is delayed. Thank you very much for patient listening. Now the next speaker will give a talk. At the end, we'll go for a question and answer sessions. Thank you very much. No time happens.
Thank you very much, Dr. Swaminathan, sir. I'm able, sir. I'm yeah.
Good evening, everybody. I hope I'm audible.
Yes, doctor.
Okay. At the offset, I'd like to thank the organizers, Dr. Meenakshi Sundaram sir, for giving me this opportunity, and respected chairperson, Dr. Shiva sir. With your permission, I start my presentation on congenital diaphragmatic hernia.
Please start.
Thank you, sir. So today I'll be covering the topic under these headings. One, I'll try to define CDH etiology and what are the clinical features and the surgical options, and would be following with anesthetic management and post-operative management, and what are the long-term concerns associated with congenital diaphragmatic hernia. So basically, it's a developmental anomaly where there's a defect in the diaphragm, and This defect permits the abdominal contents to herniate into the thorax. The incidence worldwide is about 1 in 4 to 5,000 live births, and there is a male preponderance than compared to female babies, and it is associated with a very high mortality of up to 60%. So coming to embryogenesis, so basically the diaphragm develops from two parts. One is the septum transversum, and the other part is the pleuroperitoneal folds. So here you can see in the first image, the septum transversum grows from the anterior part of the body, and the pleuroperitoneal folds develop from the posterior part, and somewhere from anywhere between the 7th week and to the 16th week, they come together and they fuse together. Any defect, developmental defect in this fusion may lead to the hernia. So there is a dual hit hypothesis. It is broadly understood that the herniation is responsible for lung hypoplasia, and the lung hypoplasia is responsible for the morbidity in these babies. However, there is a dual hit hypothesis, which states that first, there is the first insult is pulmonary hypoplasia, which may be genetic or which may be environmental. This affects the formation of the diaphragm. Following which, there is a second insult where there is protrusion of the abdominal contents into the thoracic cavity, and this further hinders the development of lung. So the affected lung is overall underdeveloped. So there are less terminal bronchioles, and bronchioles are less developed. There are abnormal type 2 pneumocytes. There's reduced pulmonary vasculature overall, and there's a resultant muscularization of the pulmonary arteries, leading to thickening of the tunica adventitia and media. And there is an exaggerated response to vasoactive substances such as endothelin-1. Here in this image, you can see cadaveric photos of the congenital diaphragmatic hernia. So the pathophysiology is basically pulmonary hypertension. This can be reversible or irreversible. So any structural abnormality, developmental abnormality, is more or less irreversible. However, because of its unpredictable response to vasoactive drugs, certain drugs can be used to try and reverse the pulmonary hypertension. There may be a resultant decrease in preload and cardiac output due to the kinking of the IVC, which may be affected by the herniation. Because of the herniation of the intestines into the thoracic cavity, there is decreased left ventricular muscle growth, and there is a right to left shunt. So in this image, here we can see that once the abdominal contents herniate into the thoracic cavity, there is hypoplastic lungs, increasing the pulmonary venous hypertension, which in turn exerts pressure into the left atrium, which results in its dilatation, and overall left ventricular hypoplasia, which maintains a right to left shunt and precipitates hypoxia, acidosis, and overall cyanosis of the child. So there are associated anomalies in this with CDH. There are several genetic syndromes. All the three trisomies, chromosomal anomalies, are also associated, and certain isolated structural anomalies such as cardiac, which most commonly is ventricular septal defect and atrial septal defect, and there may be neural tube defects, hydrocephalus, and there may also be musculoskeletal defects such as limb reduction and polydactyly and syndactyly. So there are certain indicators for poor prognosis. So antenatally, if it is known that the mother is carrying a child with CDH, evidence of liver herniation, early gestation at diagnosis, a lung to head ratio of less than 1, or a O and E lung to head ratio, which is observed upon expected lung to head ratio less than 50%, determines poor prognosis. Postnatally, if it is known that this defect is large, or there are any associated cardiac or chromosomal abnormalities, and there is there is severe pulmonary hypertension, the child has low birth weight or a low Apgar score, and the contralateral, how bad the opposite lung is affected, and bilateral congenital diaphragmatic hernia babies tend to have poorer prognosis. So there are three types of hernias. Majority of them are left-sided, and a few of them are right. Bilateral hernias are very rare, and they are basically three, which is one is hernia through the foramen of Bochdelic, which is on the posterior lateral side. This may be bilateral, and through the foramen of Morgagni, which is retrosternal or parasternal. These are usually smaller, and these are usually right-sided. Central hernias through the central defect in the central tendon are very rare. Another classification is based on the grading of the size of the defect. It is graded into A, B, C, and D. A is a very small defect. B is a defect, a unilateral defect, which affects less than 50% of the diaphragm. C is when the defect is more than 50%, and a complete defect of the diaphragm on the side is classified as D. So antenatally, how we come to know about the diagnosis of CDH. So routine ultrasound reveals 50% of the cases. Initially, there may be evidence of polyhydramnios, which may require further investigations, such as a fetal MRI, to confirm the diagnosis. There is also use of high-resolution ultrasound, which this also helps in determining whether the mother and the fetus are eligible for any intrapartum intervention. This high-resolution ultrasound can also help in grading of the severity, measuring of the lung volumes, noting of the position of the liver, and any associated comorbidities. So here is an MRI image of the fetus. Here you can see that there is a mediastinal shift, and there is herniation of the bowel contents into the thorax. These images can also be used to calculate the lung to head ratio. So the lung to head ratio is calculated by the following measurements, where they calculate the longest diameter of the contralateral lung and the perpendicular diameter of the contralateral lung over the total head circumference. So this was in various studies, it showed that this was not a correct representation of this prognosis. So they came up with the O and E LHR formula, where O stands for the observed and the E stands for the expected. So any differences between the observed and the expected lung to head ratio is known to show the prognosis better. So there are some antenatal managements, surgical managements that can be done. One is fetoscopic endoluminal tracheal occlusion, which is FETO. So the concept here is that to promote lung growth and limit the pulmonary hypoplasia. So what is done is there is temporary occluding of the trachea with a balloon, and this causes the stretching of the lung tissue, and there is increased production of growth factors and that may follow with lung growth. However, this is a experimental procedure that is usually done between 28 to 30 weeks. So in this image, you can see that a fiber optic scope is introduced through percutaneously into the fetus, and a small balloon is filled into the trachea, leading to its occlusion. And this, we hope, after performing this procedure, that the pressure that is developed in the lung helps it to grow. So all the fetal procedures are to be followed by a exit procedure. Exit stands for ex utero intrapartum treatment, and this is done at the time of delivery, and the fetus is maintained on placental circulation for this. So they can be exit to airway, where once the airway is secured of the fetus, the baby is delivered. And they may also be exit to ECMO, where if the fetus is very sick and has multiple anomalies that needs attention, the child may be put on ECMO for further management. So here are some images. I'll be starting from in the top line from left to right. So here in exit, we can see that the baby is partially delivered. Monitors are attached. An IV line is secured, and 2D echo is continuously used to monitor the fetal heart. Laryngoscopy is done either by a fiber optic or a conventional laryngoscopy. The airway is established, cord is clamped, and baby is delivered. In case we are unable to secure the airway here, what we can do is we can burst the balloon that was introduced during feto, and we can perform a tracheostomy. So if the diagnosis was not made antenatally, it can also be made postnatally because of some few clinical signs that present as soon as birth. So these features are respiratory distress, barrel chest or a scaphoid abdomen. The apex beat is shifted and there may be apparent dextrocardia. There is poor air entry, or in very rare cases, we may even hear bowel sounds in the chest. And this is also associated with hypoxia and acidosis. So for respiratory distress, the obvious next step is to take a chest X-ray, and the chest X-ray may reveal a bowel shadow in the thorax and mediastinal shift. Here is a chest X-ray of a right-sided hernia, where we can see liver as well as some bowel content that has shifted to the thorax. A CT scan can also be done. This is an image of this is also an image of a MRI that is showing herniated contents in the thorax. So the primary intervention is medical management. So medical management is basically respiratory distress that needs to be corrected by resuscitation, endotracheal intubation, and mechanical ventilation. Mask ventilation is avoided because to prevent any gastric insufflation, and the NG tube should be inserted and continuous suctioning should be done to prevent gastric insufflation. 2D echo guides the treatment because it can help us identify any associated cardiac anomalies, and it can also help in grading of the pulmonary hypertension, and it can identify any shunts that may be present. Only in children with very small hernias that have no cardiac anomalies can be considered for a trial without intubation. See, there are various pharmacological agents that are used. So these pharmacological agents help in optimizing gas exchange and reducing pulmonary hypertension, as well as to maintain hemodynamic stability. So the first and the most commonly used drug is nitric oxide, which is inhaled 20 to 80 parts per million. Other pulmonary vasodilators can be used. Sildenafil, prostacyclins, tolazolene, and dipyramidol are other examples of drugs. There is some evidence of exogenous surfactant. However, there's very less literature on its use, and there's no clear-cut benefit of using a surfactant. Prostaglandin E1 to maintain the ductus open, to maintain forward flow of the cardiac output. Inotropes and vasopressors can be used to maintain organ perfusion, cardiac function, and reduce the shunt. Noradrenaline is the drug of choice. Dopamine, dobutamine, and milzolone have also been used. The choice of the inotrope depends on the echocardiography. So when it comes to ventilator management, the main this recommended ventilation is permissive hypercapnia or gentle ventilation. So there are some European guidelines that suggest that we use very low peak inspiratory pressures of 25 centimeters of water with peeps of 3 to 5 and a rate of 40 to 60 per minute. And we have to use the lowest FiO2 that can maintain a pre-ductal saturation of 90%. If conventional ventilation is failing, then we can proceed to high-frequency oscillatory ventilation. In cases of severe hypoxia and hypocapnia, the, liquid ventilation with perfluorocarbons have also been tried. And of course, we have ECMO when all else fails. So the criteria of ECMO, again, this has been defined by the European guidelines, which say that the peak inspiratory pressure more than 28 centimeters of water on conventional ventilation, which needs to achieve a saturation of 85%. Raised PCO2, which is not optimized on ventilation. Pre and post ductal saturation that are consistently low, which is 70 to 80%, a low pH and a high serum lactate, or they may be refractory hypotension despite fluid and inotropic therapy. These are the criteria for ECMO. So coming to surgical repair, there are basically primary repair where the contents are moved out of the thorax into the abdomen and a patch or a primary closure is done on the defect. It can be of two types. One is an open repair and the other one is a thoracic repair. So the open repair is for larger defects and if the liver is also herniated and for sicker babies. Here a subcostal incision is taken. However, once the contents of the thorax are moved back into the abdomen, there may be a risk of abdominal compartment syndrome because the abdomen musculature may also be maldeveloped. In a thoracoscopic repair, the position is lateral and there is CO2 insufflation in the thorax. However, this has a long surgical time and a very high recurrence rate. The advantages are less postoperative pain, less ventilation time, early feeding, shorter hospitalization, and less scarring. However, the disadvantages is that there is very high PCO2 and severe acidosis and decreased in cerebral oxygenation saturation. And this may be very difficult to manage with conventional ventilation intraoperatively. Higher ventilatory pressures, if used, worsen lung injury and pulmonary hypertension. So timing of surgery, this is not a surgical emergency. Previously, it was considered that children should be operated within 12 to 24 hours. However, now because we understand that pulmonary hypoplasia is a major factor in prognosis, the management of pulmonary hypertension takes precedence and surgery can be delayed up to 48 hours, 48 to 72 hours to stabilize the patient and take up the child for surgery. So the recommendations again for the Euro Consortium recommend that the mean arterial pressure should be normal for gestation, a pre-ductal saturation of more than 85 to 95% on a FiO2 of 50, a close to normal lactate of 3, and a urine output which is 1 ml per kg per hour should be the perfect time to take for surgery. The anesthetic challenges are of course hypoxia, there may be hemodynamic instability. management of pulmonary hypertension and right ventricular failure. Of course, with all neonates, there may be hypoglycemia, hypothermia, hypocalcemia, and we need to come up with a ventilation strategy post-operatively for this child. Routine investigations, hemogram is recommended. ABG, that may show a mixed respiratory and metabolic acidosis and severe hypoxemia and hypercarbia. Electrolytes are noted, blood sugars, cross-matching is done, a chest X-ray and a CT thorax. When it comes to monitoring, a precordial stethoscope and esophageal stethoscope is recommended. There is continuous ECG monitoring. There are 2 saturation probes, pre and post-ductal. Capnography may not be accurate because of low tidal volumes in these children. So capnometry can be used. If we are ventilating this child on a machine, then we can note the inspiratory pressures and the FiO2 values. The ABG is done if the duration of surgery is longer. Invasive blood monitoring is preferred over non-invasive blood monitoring, preferably on the right-hand radial artery, because we can take an ABG sample from this, and that will give us an accurate representation of a preductal ABG. CVP monitoring for fluid management, and of course, temperature management. Pre-medication, these neonates usually don't require routine pre-medications. However, atropine can be given 20 mics per kg. This helps in reducing harmful vagal responses and to reduce any secretions. Induction and intubation, here it is recommended to do a wake intubation and with inhalational agents. Bag and mask, as I mentioned, should be avoided till the airway is secured, and muscle relaxant can be avoided for the securing of airway, and intraoperatively nitrous oxide can be avoided. So the child can be maintained with air and oxygen with an inhalational agent. For analgesia, we can use opioids, a caudal catheter, or some regional blocks can be given. And intraoperatively, child can be relaxed once the airway is secured with our regular non-depolarizing muscle relaxants. So our ventilation strategy should be to maintain a close to normal ABG. Our oxygen should be around 80 to 100. Carbon dioxide 25 to 30. Maintain a saturation above 95. Close to normal pH, and respiratory rates, so higher respiratory rates with low tidal volume should be preferred, and FiO2 can be adjusted depending on the partial pressure of oxygen, and low airway pressures less than 15 to 20, so as to not cause any harm to the contralateral lung. Fluid management, we need to correct the deficit. We can use Hartmann's formula or 10 ml per kg. Dextrose containing isotonic solution is recommended, and transfusion of blood products as necessary. So once the cavity is closed, if you notice a second sudden decrease in compliance and saturation associated with hypertension and bradycardia, the first thing that should come to our mind is pneumothorax. So ICD should be introduced, and we should use very low airway pressures. Post-operatively, these children are electively ventilated. That is why opioids and relaxants may be used. Ventilation goals again should be adjusted to maintain a normal ABG and while giving low tidal volumes and low airway pressures. So post-operatively, again, our goals remain to treat acidosis and try to correct the pulmonary hypertension as much as possible. ECMO can be considered at this step also if oxygenation is not maintained. A wake extubation is to be planned when the patient is maintaining partial pressure of oxygen on minimum FiO2 with adequate respiratory effects. So the prognosis of these children depends on a few factors, which is one, how well the ipsilateral side, the affected side behaves or opens up after surgery. If it is 50% or more of the contralateral side, it signifies a good outcome. A late presentation, that means there's a better prognosis because because it is said that the lung has had time to develop. So a late presentation in late gestation can show can be better prognosis. Two parameters are measured. One is ventilation index, which is respiratory rate times the arterial pressure, mean arterial pressure. If it is more than 1000 with a partial pressure of carbon dioxide with 40, it signifies a poor prognosis. And the other is the oxygenation index, which is mean arterial pressure times the FiO2 times 100 by the partial pressure of oxygen. Less than 40 determines a poor prognosis. So long-term sequelae, 87% of these children have some long-term sequelae, the most common being reherniation. These children may have recurrent respiratory tract infection. They may have a restrictive lung disease pattern, and they may have bronchopulmonary dysplasia. Gastrointestinal, they may have reflux and failure to thrive. And neurologically, there's very high incidence of cognitive impairment and sensory neural hearing loss in these children. So current research that is going on is FETO versus total, which is total is basically total occlusion of the trachea. The role of ECMO and the timing of surgery that can be done on ECMO, and a novel therapy, antenatal therapy to improve lung development by giving maternal giving the mother corticosteroids to help the lung to develop. So for my fellow postgraduates, the exam questions, congenital diaphragmatic hernia is an exam question, 10 marks, and this is the recommended reading. I have gone through all these references to collect my material for today. Thank you very much.
Am I audible? Am I audible?
Yes, yes, very good.
Yeah, thank you. Samir, it is an excellent presentation. Sorry, there is some disturbance in my system here, so I could not speak earlier. All the speakers have done very well. Now we'll take certain questions from the chat box. When do you declare a patient brain dead? It is, I think, Chitra. Chitra, am I audible?
Yes, sir, you are audible, sir.
Yeah. When do you declare? Yeah.
A patient can be declared brain dead when there is a patient is an irreversible coma, when there is an absence of brainstem reflexes and cortical reflexes. So there are certain tests to declare brain dead, sir. And the tests are absent pupillary reflexes, corneal reflex, and gag reflex, and the Olsay phenomenon, and oculovestibular test we do, and apnea test we do. So after doing all these tests, we declare a patient as a brain dead patient, sir.
Okay. This question, what is the best sedation for head injury patient?
Yes, sir.
Yeah, please take.
The head injury patients is an older drug, thiopentone sodium. It's the best drug for sedation of choice. But only thing is, it may not be available in emergency rooms. So it's a short-acting drug. It is circulation time is very fast. It has got a better cerebral protective agent. It maintains the cerebral metabolic reuptake oxygen. At hypoxic state also it's safe to use. But only thing is availability is very rare in emergency room. Second choice is going to go for a propofol. Not a full dose as like 2.5 milligram per induction dose. Can use 1 to 1.5 milligram propofol per kg body weight and go for sedation. Other drugs are unsafe. Ketamine and dexmedetomidine, all these drugs may not be good for acute phase when the patient is in head injury.
One more question, sir. How will you differentiate pathological unconsciousness and sedation-induced unconsciousness?
Yes, sir. It's a nice question. Pathological unconsciousness and drug-induced unconsciousness. In any type of sedation, whatever use, brainstem reflexes may not be temporarily obtended. Brainstem reflexes maintained only the patient will be sedated. Even the patient goes for a sedation scale as per I said the 6 or is unarousable state. The reflex will be maintained, sir. Pupillary reflex and light reflex to pupillary response and dorsal movements. These two things will be maintained. Dorsal movement sometimes may not be brisk, but brainstem reflexes will be maintained. Most of the times, if it is used in the ICU sedation, have a swallowing reflex and other brainstem reflexes, pharyngeal, laryngeal reflex will be maintained in other type of sedation, but brainstem reflex will be absent in comatose state induced by neurological cause.
Yeah. There's one question for Dr. Samir. Samir, in feto, whether lung expansion is guaranteed, bowel moves up in the thoracic cavity.
These are experimental procedures, so there is no guaranteed improvement in lung function. However, it has shown some benefit to preserve the because inside the womb the fetal lungs are filled with the amniotic fluid. So once we occlude this, there's expectation that the pressure develops and helps the lung to expand. However, this is experimental studies, so how much this helps is yet to be understood.
Dr. Samir, that question was asked by me only.
Yes, sir.
My point is, even if the lung expands, because of that defect in the diaphragm, the bowels will also move. Again, it is only a common sense. It's just like a tug of war. Lung will expand, bowel will not allow it to expand. So I don't know, but anyway, at the end you have mentioned it is feto versus toto.
Sir, I will answer that question, sir.
Yeah.
Meenakshi, sir, that the experiments, that feto procedure versus no feto, there is definitely a better survival chance in the babies where feto procedure is done. That gives a chance when you are occluding the trachea. It also helps in retaining the amniotic fluid as well as the lung secretions, which will expand and allow the lung to grow. And that may also partially inhibit the push-up of the gastric contents into the thoracic cavity. This is what is thought. There is one more question. Is it advisable to intubate awake in neonates? From Dr. Muthukumar Rajagopalan.
So in these CDH, all the guidelines that I have read through recommend awake intubation, so as to we need to make sure that the airway is secured before we paralyze the child.
In our center, how do you practice?
So in our center, we once the once the baby is delivered, we usually know beforehand antenatally that the baby is suffering from diaphragmatic hernia, and we deliver the baby and we assess the baby initially for the first 10 to 15 minutes. We do a Apgar and we assess, and we decide to intubate the child without a relaxation. And unless only if the child is with a small defect and maintaining airway and maintaining saturations well, these are the children that we don't intervene.
How about inhalational intubation?
Induction? Yeah, when these children come to surgery, yes, we use inhalational induction with sevoflurane, and we secure the airway. And then we relax the child with our routine muscle relaxation.
One more question I want to ask you. See, fetal procedure you have done and you have occluded the trachea, and patient lands in an emergency, wherein you have not removed the obstruction, and how do you proceed in an emergency?
Yes, so this is the worst situation that we can be in. The recommended step right now in this situation is to burst the balloon in the trachea, either by a needle or, and if we have time, under ultrasound guidance, or if not, with a needle percutaneously.
Meenakshi sir's question, whether you have any personal experience with ECMO?
So neonatal ECMO, yes, but not in CDH management, sir. This is also a very new and there's a lot of ongoing research going on this because the evidence is not yet known whether ECMO gives us any benefit for these babies.
Actually, there is a suggestion. If the lungs are hypoplastic and intubation and ventilation will not this thing, in such a case, there is a role of ECMO. Yes.
Whether in any center in India they are practicing ECMO for this neonate?
In our center, we are not, sir.
Anyway,
ECMO in unit, yes, sir, it's being done, but not in our center, sir.
where in any of the centers in India?
Yes, in my one of the hospitals here, Rainbow Hospital.
Rainbow Hospital, yes.
We have neonates. We have they have a separate ECMO team, sir.
There is one more question from Vasanta. To prevent collateral pneumothorax, is it necessary to put contralateral pneumothorax? Is it necessary to put chest tube on the contralateral?
So chest tubes are basically ICD is not recommended routinely unless and until the cavity is very large or there is evidence of pneumothorax. An abdominal drain can be kept in place of a ICD in these children.
Now, my next question is to Dr. Swaminathan, sir. Sir, am I audible?
Yes, yes, you are audible.
Yeah. Sir, what are the adverse effects of ICU sedation, sir?
Dr. Swaminathan is not here. Dr. Swaminathan. So you go for the next question. We will contact him. He's
Okay. Swaminathan. Dr. Samir, this question is to you. How often do you elective ventilate the congenital diaphragmatic hernia child?
So almost all the babies land up with the elective ventilation. Sir. Very rarely, if it's a small defect and if the contents are only bowel and there's primary closure that is done, then for these babies we give a trial extubation post-operatively. But we make sure that this child is observed before shifting the child in the post-operative unit, so that we make sure that child is stable before shifting.
Yeah, in our center, most of the children, they are already intubated and shifted to OT. So in such cases with large defects or especially if liver is herniated, in such cases, we will continue post-operative ventilation for these children.
Sir, this is Swaminathan, sir.
Yeah.
What you asked, sir? You asked about the side effects of?
ICU sedation, prolonged ICU sedation, adverse effects.
In ventilated patient or non-ventilated patients, sir?
In non-ventilated patients.
Non-ventilated patient, we restrict the use of sedation. What I said is different modalities we used to have that.
Yes.
We restrict the sedation is patient is go for we plan for intubation when the patient becomes worse and plan. At the most maximum is we come across this late arousal in poisoning, systemic disease like sepsis, all those multi-system disorder only that happens is the sedation arousal is delayed, sir. Otherwise, there is no definite for a single person variation about the complications, sir. It varies from individual to individual, sir.
Yeah. Delirium is supposed to
hemodynamic instability comes, it will be transient, sir.
Okay.
If it is a neurological thing happens, our titration of sedation is be compromised, I feel. It will compromise, will go for a neurological deficit. Our titration definition is limited. There is no chance of irreversible neurological happenings will be there. Only hemodynamic instability to be observed very closely in all types of drugs which may produce hemodynamic alteration during induction or maintenance. So only I said about multimodal approach is safer when you use an ICU sedation, sir. Not a single drug and all the time, sir. mesmerization.
Sir, how often do you find delirium in benzodiazepine sedation patients?
It is very common in ICU patients within 3 days, sir. If you continue benzodiazepines for more than 3 days repeatedly, and actually OPC poisoning on ventilation, continue sedation for 3 days without any alteration, in the drugs. Single drug, if you give it for 3 days continuously, you get after 70 days you develop this type of psychosis-like picture. Sometimes for us in our setup, we are seeing OPC poisoning and other cases. So there's a confusion about either poisoning induced atropine psychosis and the psychosis induced by the withdrawal of the benzodiazepine compounds. That's one major disadvantage we are facing here. In the situation, physicians are very fond of continuing atropine even after 4 or 5 days. They see only that secretions and they don't mind about what is the number of days the patient may be on one patient. So I have observed more than 72 hours, the same drug we are giving, the patients go for psychosis.
There are some more questions, sir. For Samir, do you need sedation for these babies on ventilator pre-procedure and post-procedure?
Yes, sir. Definitely, we need sedation pre-procedurally, and post-procedure we need sedation as well as analgesia. Muscle relaxant may be are indicated if there is too much ventilator asynchrony. Even relaxant can be used, but not routinely.
And this is to Swaminathan, sir. Can
Yes, sir.
naloxone be routinely used as a test to differentiate pathological or sedative unconsciousness? This is from Dr. Suresh Kumar.
I don't think it is unless otherwise you got a definite idea of patient is on a high dose of opiates. There is no fixed roles of naloxone as a test dose. We cannot practice in all the cases unless there is proved is definitely due to opiate drug overdose.
Yeah, actually, at this point, I want to tell something. Sometime back, we had cases of tramadol poisoning. The
Yes, sir.
children, when vaccinated, instead of paracetamol, the babies were given tramadol tablet, which were supposed to be broken into 3 or 4 pieces and given. And they landed up with respiratory depression in our hospital. And we have tried giving naloxone, and these patients, most of the patients did not require ventilation. So
Okay.
that problem we
accept
had.
Yes, sir. Yes, sir. I think you experience new.
How they have made out that it is a tramadol tablet?
What ANMs were distributing the tablets. They were supposed to give paracetamol. Instead of that, they have given some 300 milligram this tramadol tablet. So once it is made into 4 pieces, still it is a high dose for a pediatric age group.
It's okay. How I think because they will give a single tablet. So how they have identified that it is a tramadol tablet? Because
children are becoming unconscious, and that too from one particular center, and we are shifted to our hospital en masse. So it is recognized that, and they have again rechecked and found that instead of paracetamol, they have given some other tablet, tramadol. So these children were managed in ICU in pediatrics in our hospital, and all of them recovered safely.
The same thing. Again, I want to add one more thing here. In PG Chandigarh, propofol injected patients, 5 patients dropped dead even before surgical incision. So I want all the anesthetists, Propoven, they have given that packing also. Propoven, that is a trade name. If it is there, you please avoid using it.
Yeah, there in Chandigarh, the propofol is purchased from the outside medical shops.
Anyway, that brand, we are not worried about that administrative thing. If it is Propoven, VEN, you avoid using it because we want to be on the safer side.
Yeah. One more question from Dr. Suresh Kumar. He asked earlier about this thing, naloxone. Now he's asking flumazenil also.
Flumazenil?
For benzodiazepine reversal.
Whether by using.
Sir, we have tried, this successfully has come out, sir.
Okay. Meenakshi sir, any more questions?
No, I think there is no question in the chat box.
Yeah, I have come.
Checked. I think Dr. Prema Madam asked one question at the end. All the questions you have covered, sir.
Yeah.
All the questions.
And anyway, my logic is when.
Yeah. One question, sir. If the baby presents later, how do you intubate? That is from Dr. Muthukumar Rajagopala. If the baby is presented later, how do you intubate?
So this is definitely a very unusual situation because we are very careful while extubating these babies. However, if at all we have to re-intubate, I would recommend using a very short-acting sedative to secure the airway and then continue on sedation.
But routinely in your hospital, you manage with inhalation induction.
Yeah, inhalation induction, sir. I'll answer that. If the child is less than 1.5 kg in such children, we continue ventilation in the post-op period. And smaller defects and more than 2 kgs, when the child did not require any immediate post-delivery intubation, such cases we do under inhalational inductions.
Because for the postgraduates, the routine question in the examination is whether it is IV line and after that intubation or first inhalation induction, then IV line. That is a routine question they will ask. Without IV line, whether you will go for inhalation induction or not. So I think we senior anesthesiologists can do that. Without IV line, inhalation induction, I think only experienced anesthetists can do. For the postgraduate, I think they have to answer only after securing the IV line, I will go for induction.
True, sir. But I want to add one point here. Most of the children are crying and they will be resisting your attempts. For securing IV line or anything, first again we need to have oxygen.
It's the reason why this is a routine question asked in the examination. I want to till the postgraduates pass that examination. I want them to, I think if Dr. Shiva is the examiner, he will accept first inhalation induction, then IV line. But most of the examiners, they want IV line because if any complication occurs, there is no possibility to revive the child. So always IV line is a lifeline. So till they pass the post-graduation, then only the controversy comes. If I say Dr. Shiva will argue the crying child, it is very difficult to calculate. So it's a routine question asked in the examination.
Yeah. True, sir. True. But there is one center here who practice smaller daycare ophthalmic procedures without even IV line. Sevoflurane induction and then IGL, proceed with the surgery, recover the child and send back. They don't even put an intracap. No, but these should not be discussed for
no, never.
For postgraduates, definitely securing IV
line. No, it is not only, see, the way in user, it is not only for postgraduates. Any anesthesiologist without IV line, if they are anesthetizing, it is a crime. It is a crime. That's right, it is the risk they are taking. Fine. No more questions?
Meenakshi sir. Sorry for the technical problem. I could not audio.
See, if we have problems, technical problems in anesthesia management, it is a problem.
That also is a big
software, hardware problem is a problem. Software problem is not a problem. Anyway, we are able to listen to the SPB's voice.
Oh, thank you very much. And thank you, sir, and thank you your whole team, Pudukkottai team, for giving me an opportunity. And my intensivist and on behalf of my intensivist and my PG, Dr. Chitra, I thank you profoundly.
Thank you, sir. Excellent lecture by all the four, because the chairperson usually is totally expertise in moderating, and as such that postgraduate has performed very well. We are happy that Pondicherry is having a bright anesthesiologist in future. And my classmate, Dr. Swaminathan, we used to call him as Sound Swaminathan, but he has reduced his decibel today by a pre-recorded meet. And Dr. Samir has clearly explained, very clearly explained about that CDH. It is a total revision for me, because I have anesthetized a baby only 8 years back. and it is a total revision for me, and I am very happy that I have anesthetized DEF, CDH, and CLE. In that way, I am happy, and now we congratulate and thank profusely all the 4 faculty, and we will meet at that 50% target in the next Wednesday. I hand over the session to Dr. Suresh Kumar, our president.
Thank you, sir. Thank you very much. Excellent lecture, sir. Excellence by Dr. Swaminathan, sir, Dr. Samir, and Dr. Chitra. Very good coordination and compiling of as a chairperson, Professor Dr. Shiva, sir.
We are on time, President, sir. We have to make on time also.
Everybody is on time. I just wanted to tell also. As president of ISA, I wholeheartedly thank all the speakers and our chairperson for coming here, sharing their valuable time with us and enriching our knowledge and for the postgraduates. It is official Thanksgiving. Our treasurer, Dr. David, is waiting. Over to Dr. David.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM sir, for successfully conducting the 25th webinar of the Pudukkottai Budan. Thank you, sir. And I would like to thank today's chairperson, Dr. Shiva, professor of Osmania Medical College, Hyderabad, for sharing his wonderful experiences. Thank you very much, sir. And I also thank other speakers, Dr. Swaminathan sir and Dr. Samir Nath and Dr. Chitra for a wonderful academic session. And thank our president, Dr. Suresh Kumar sir, and secretary, Dr. Perisami sir, and other faculties and postgraduate for making successful Pudukkottai Budan. Thank you. And A1 Logics and Accurala for technical support. Thank you.
We can end the meeting. A1 Logics, we can end the meeting.
Thank you, sir.
Thank you, sir. Thank you. Shilpa, you can.
Log out at last.